This
syndromes,
conference will now be recorded.
For these inherited syndromes, they have this first hit, and then that causes them to be more likely to get the second and third hits that eventually result in cancer or malignancy. And so for these, this would be the polyposis syndromes. So that's FAP, MUT, associated polyposis, and then the various hamartomatous polyposis syndromes, which would be like the Peutz-Jeghers syndromes. And then finally, the non-polyposis syndrome, which is the Lynch syndrome. And then the last category is a category that doesn't necessarily fit into the other two categories. And that's most likely because we haven't found the genes that we can specifically categorize these patients into. But these would be familiar syndromes. So this is a patient that has a strong family history of colon cancer, but again, we can't identify the mutation that is causing them to have these the colon cancer. And so this is called familial colon cancer type X. And there's, again, just non-specific mutations. Likely in the future, we will figure out exactly what genes are causing it. But as of right now, they go into this category as familiar syndromes. The leading theory on the way that colorectal cancer develops is this adenoma carcinoma sequence, and the theory is that it arises from an adenoma that then becomes dysplastic and then eventually gains the ability to proliferate and become invasive, with the end result being malignancy. Here's a couple of diagrams showing that. The order of loss of some of the functions or gain of function of some of these genes are listed here on the side. And this is kind of the classic pathway. I'm going to kind of discuss a few of the other pathways that they think leads to colon cancer malignancy. But this is the way that the vast majority of colon cancers arise. And it's kind of this first hit, second hit, or third hit type theory. And so you have a normal epithelium, and almost always the first hit that these cells have is the loss of the Apc gene. So this is the gene that's seen in FAP syndrome. And we're going to go into these a little bit more in depth, but you have a loss of the Apc gene, hyperproliferation of the epithelium, which then causes an early adenoma. The time frame between here, these two segments, is about 10 years, which is kind of the basis for your colorectal cancer screening, being every 10 years, as long as it's kind of within normal or 1 to 2 polyps. And then you get a second hit, and this second hit is usually KRAS, so a mutation in the KRAS. KRAS is the second hit, and then your third hit is going to be the loss of the 18 chromosome, which they think is this DCC gene, but there's also a couple of other genes within that on the chromosome 18 that they think might also be associated with colorectal cancer. Again, we're going to get into these a little bit more specifically. And then finally, most of the research shows that kind of the last step before malignant conversion is this P53 loss of function, which is in the chromosome 17. And then that's, at that point, is kind of when you get into the malignancy stages of colorectal cancer. It doesn't have to follow these lines, but kind of the best research that we have kind of shows it going along these lines. Again, here, this just shows a small adenoma going into a large adenoma. The time frame here is about 10 years, and then a large adenoma becoming high grade, and then it becoming an invasive carcinoma with subsequent hits onto the genomic sequences. Wrong way. And so that's kind of what I like to think of the classic pathway, where you get this chromosomal instability. As more and more research comes out, there's two other pathways that are suggested as other ways that patients can obtain colorectal cancer. And the next way would be this microsatellite instability pathway or mismatch repair pathway. And then the third way is the CpG island methylation phenotype pathway, or CIMP. And this is also known as the serrated pathway, because when patients who obtain colon cancer through this pathway, they typically form these serrated polyps, which is unique compared to the other two pathways. This is, again, kind of the showing this stepwise obtaining of the Apc KRAS, loss of the 18th chromosome, which includes DCC, but then these other mutations as well, and then loss of the heterogeneity, that's what the LOH stands for, of the 17th chromosome, which is where the TP53 is located. But what this chart also shows is that there's multiple different factors and there's different ways that patients can get this. And so kind of this chromosomal instability pathway is the typical pathway that we're seeing up here. Other pathways are going to be this mismatch repair pathway and the which is also known as this microsatellite instability pathway, as well as the CIMP hypermethylation. There's a lot of overlap between these different pathways. So kind of you have the majority of colorectal cancers over here in the chromosomal instability. And then over here you have that microsatellite mismatch repair pathways, which overlaps with the CpG island methylation. And we're going to explain them and then kind of go back to this chart to kind of look at how it affects it. These are, again, just the pathways and what we'll see here. The kind of big things to note on the differences between these pathways is that in chromosomal instability, you have microsatellite stability, versus in these other two pathways, you start to see microsatellite instability and a high microsatellite instability. The importance of all this, we'll get to when we break it down individually, is can we tailor our therapeutics to the genetics of the colon cancer itself, rather than treating all colon cancers as the exact same. And so that's why I'm going into the specifics between these three pathways, is because as we study this more and more, we're starting to develop different therapeutics that will benefit certain pathways over other pathways. And so when you look at it, you can see that, okay, this serrated pathway, the CIMP pathway, typically has a BRAF mutation, whereas the other pathways don't. And so that'll definitely change your therapeutics, or it could potentially change your therapeutics as far as what chemotherapy agents you use. Same with the KRAS mutation. And so the first pathway, which we've talked about already, is this chromosomal instability pathway. 80% of all sporadic colorectal cancers end up kind of going through this pathway. This pathway incurs just changes in the gross, kind of the gross structure of the chromosome, where it gains and loses large segments of the chromosome. Large segments of the chromosome are rearranged, and then eventually they lose the heterozygosity of the chromosome, resulting in multiple gene copy variations. This pathway can also be inherited, and when we see it inherited, this means that these patients kind of are born with this APC, this first hit, which is the APC loss, and these are the patients that have familial adenomatous polyposis syndrome. And that's less than 1% of all colorectal cancers. The next is this microsatellite instability pathway. This is 15% of all sporadic cancers, and then 1 to 3% of all colorectal cancer that's inherited um, through this pathway. So 1 to 3% of all colorectal cancers is going to be inherited via this pathway. This microsatellite instability is a dysfunction in these mismatch repair genes. And so these genes are listed here. MSH2 and MLH1 are the ones that I hear the most. And in my research making this presentation, these seem to be the genes that were kind of most commonly affected and had the largest percentage of kind of the patients with colorectal cancer had mutations in these genes. If there's a germline mutation in any of these, this is how patients get Lynch syndrome. And so patients with Lynch syndrome have a germline mutation in these genes. The reason it's called microsatellite instability is because there are repetitive DNA sequences within our genome, and these sequences, because of the repetitivity of these sequences, you get slippage of the polymerase enzyme, and what happens is the polymerase slips back and it will insert another like segment of 3 for the within the gene. The mismatch repair gene typically excises these areas and then splices them back together. However, if you have mismatch repair dysfunction, then you're unable to correct for these replication errors, the result of which causes sequences to repeat hundreds and thousands of times. And this repeat of these kind of 3-segment nucleotide segments is called microsatellites. And so that's where we get the term microsatellite instability. Later in the talk, when we see microsatellite instability high or microsatellite instability low, that's looking at how many sites within the genome are affected by these microsatellites, and the cutoff is between 30 to 40% of these kind of microsatellite spots, whether or not they have those kind of an expanded replication error. And then this last pathway, which is very common with the has a lot of similarities between the mismatch repair pathway, is the CpG island methylation phenotype, or the CIMP pathway. This is the serrated pathway because they typically create these serrated polyps. They have a high frequency of methylation at the promoter of the mismatch repair enzymes. And so basically this methylation causes downregulation of those enzymes, which then cause less mismatch repair to actually happen because they're not producing those enzymes. So again, just looking back at the slide I showed earlier, here you have chromosomal instability that typically has a KRAS mutation. Those are going to be the majority of colorectal cancers, up to 70% of sporadic colorectal cancers. In the mismatch repair pathway, you have microsatellite instability high, and then you have a mutation at these MLH1 or the mismatch repair genes. And then for the CIMP pathway, you have high CIMP, which is the methylation at these sites. You have high microsatellite instability because you've downregulated the mismatch repair enzyme. And then here you have methylation at these mismatch repair gene sites. One thing, I was a little unclear exactly how it happens, but typically if you have a high microsatellite instability and a BRAF mutation, that usually occurs because you get microsatellite instability through methylation versus mutation. And so this can kind of help lead you to say, okay, I have a patient, they have high microsatellite instability. I'm not sure if they have Lynch syndrome. Because this is the category with Lynch syndrome, if you have a BRAF mutation, it's unlikely that they have Lynch syndrome, because BRAF mutations typically are in the category of the methylated group or the serrated pathway.
Yeah, Kyle, just to kind of drive that home. So we test basically all colon cancer now gets tested for MSI high, right? So just the tumor gets tested. The next step, if you have MSI high on the tumor, is to do what?
To KRAS or BRAF mutations?
Right, so test BRAF. If BRAF is positive within the tumor, then you're done. That's not an MSI high tumor. And then if the BRAF is negative, what would your next step be?
To consider genetic testing for Lynch syndrome?
Yeah, you would test the patient's germline for MSI or for MMR mutation, right? So the PMS2, MLH6, MLH1, I think I'm forgetting the fourth one, but so you look specifically for Lynch syndrome at that point. But that's the algorithm that you guys should all kind of know now. Everybody gets tested MSI high, then you test BRAF. If you're BRAF positive, you do not have an MSI high tumor. If you do have an MSI high tumor, especially if it's a young patient with family history, et cetera, right-sided tumors, then you would test for Lynch syndrome. So now you're testing the germline, not the tumor. Now you can have, one thing that kind of confuses people sometimes is you can have an MSI high tumor without having Lynch syndrome, right? So that means your tumor's mutated, but your germline is not. Make sense?
Can you clarify something that you just said?
Yeah.
So you said that if we test it and it's MSI high,
Yep.
and then BRAF is positive, you then said it's not MSI high. I mean, technically
Correct.
the tumor still remains an MSI high tumor. We just don't put it in that category. Is this just a semantics thing I'm getting confused about?
It's not. I mean, it is and it isn't, right? Because they don't act like MSI high tumors. BRAF mutated tumors are much more aggressive. They metastasize early and often, and they're really bad actors. So BRAF is mutated in about 5% of metastatic colorectal cancer, and they are really bad actors. So an MSI high tumor, if you have an MSI high tumor, you kind of high five and you say, great, we can do a lot of things with this. If you have a BRAF mutated tumor, you are sad because there's not a lot of options.
It's just categories based on the behavior of the tumor.
Yeah, because again, it's not an MSI high mutation, it's a methylation. So it doesn't make a bunch of neoantigens that you can exploit with immunotherapy. So that's the difference.
Thank you.
And then just to clarify, Tim, the BRAF is mutated in 5% of colon cancers, but it's much higher in a metastatic colon cancer, isn't that right?
I'm trying to think of the study. No, that's metastatic. That's metastatic because that's based on.
Oh, is it? I thought it was a lot higher.
No, that was Chun published that study from Anderson, and it was looking all at metastatic.
Okay, maybe I'm thinking of KRAS. Okay, yeah, that's fair. Thanks.
Okay, thank you guys for that. Next, I just wanted to kind of talk about some of the mutations individually and look a little bit more specifically into why we as surgeons care and how that what that means to us as far as treating the patient. And so this KRAS proto-oncogene GTPase, this is a mutation that occurs in 50% of all colonic adenomas greater than 1 centimeter. So this is something that occurs in the majority of cancers that eventually, or of colon malignancies. However, it's rare in the smaller adenomas. So if you remember that chart as far as the sequence from adenoma to malignancy, this is something that happens a little bit later down the line, rather than the initial hit. And then there's thought that this mutation is a little bit more common in proximal colon cancers. The reason we care is because there's 2 genes that essentially have level 1 evidence for prognostic and predictive significance, and that's the KRAS and the BRAF. And so the recommendations I read said really we should be getting routine KRAS evaluation for anything greater than stage 1 colorectal cancer. And so that I think here we're starting to, or we screen all of our colorectal cancer patients for the KRAS mutation. other kind of clinical significance of this mutation is that some of the fecal colorectal cancer screening, such as Cologuard, they will test the stool for this KRAS mutation, and so that's another way that it's used. There's if a patient has a KRAS mutation, it is typically resistant to the anti-EGFR therapy, and so you want to think about that if they're if you plan on giving them chemotherapy. And then finally, there's potential to go after this mutation for additional therapeutics. It needs post-translational protein modification by farnesyl transferase, and so there's development right now for farnesyl transferase inhibitors. Next
Kyle,
is BRAF.
Kyle,
Yes.
there's also direct RAS inhibitors that have come out, and one of them is in, I want to say, a phase 3 study right now. So that's kind of down the line, right? More and more of this stuff is coming out where you find these mutations that are common, and then you make a small molecule inhibitor to directly inhibit that protein. So just like think BRAF MEK in melanoma, people are now doing the same thing for RAS. The problem is that most people think that probably it'll just mutate around the RAS because RAS is so kind of high and common. It's high in the sequence of proteins, and it's very, very common, the mutation. So, you know, it may come down to like giving a RAS, RAF, and MEK inhibitor all together to have effect, but that stuff is all kind of coming down the pipeline.
For BRAF mutations, the BRAF V600E is the most studied, and they think there may be some variance as far as which BRAF mutation you have. As we talked earlier, this is actually only in less than 10% of sporadic colorectal cancer patients, and then it's within that serrated pathway or the CIMP pathway. The reasons we care is this is another gene that has level 1 evidence for prognostic and predictive significance. Typically, these patients have a worse prognosis. The BRAF is predictive of more advanced cancer or recurrent colorectal cancer. However, there's also variance as far as it appears that BRAF is has a little bit better prognosis if it's in an MSI high tumor versus a say an MSI low tumor. There's some prognostic differences there. This is also tends to be resistant to anti-EGFR therapy, and then we kind of talked about that. It's if you have an MMR or an MSI high tumor, it's unlikely that it's Lynch syndrome if there's a BRAF mutation. This is the Apc gene. It's on chromosome 5. I know sometimes people talk about that, or it's in when I do AppSite review questions, sometimes they ask about which chromosome these genes are on. Almost the majority of sporadic colorectal cancers have this as a somatic gene mutation. And then I really couldn't find any sort of therapeutic reasons of why this kind of gene mutation matters to us, other than it's the vast majority of these colorectal cancer malignancies have that. This is the P53 gene. They call it the guardian of the genome because it causes apoptosis if the DNA is damaged. Some of the things I saw as far as clinical significance is that if the tumor has a P53 mutation, there tends to be worse outcomes and shorter survival. However, there's potential therapeutics to target the P53 mutation. This is DDC, the DCC deleted in colorectal cancer. This is on chromosome 18. So in that progression, there's that deletion of chromosome 18. And so the next few genes are on chromosome 18. So they're unsure which one actually causes it. But DCC is one of those genes that they talk about. For if you see DCC, there's trends towards the prognosis for a stage 2 DCC negative colorectal cancer to be worse, that prognosis to be worse. So if they have colorectal cancer and they don't have this mutation, their prognosis is typically worse. And so things like this, as we study more of it and we understand more of the genetics, we can start to treat based on this. And so potentially, if it's a DCC negative colorectal cancer, you might treat a stage 2 more like a stage 3 because of kind of it's a worse prognosis. And so maybe they could get adjuvant chemotherapy. These are the kind of 2 other genes that are on chromosome 18 that they think leads to colorectal cancer. The SMAD4 used to be known as the deleted in pancreatic cancer. I believe that mutation is in about 60% of pancreatic cancer malignancies. This is a downstream signaling pathway of the TGF-beta, and this is typically the mutation that they believe is in the juvenile polyposis syndrome, if it's a germline mutation. Just want to touch on BRCA genes real quick, the BRCA. Typically breast and ovarian cancers, they believe BRCA1 has an increased risk for women age 30 to 49. They haven't really shown an increased risk of colorectal cancer after the age of 50. However, and there's not really any clear guidelines on increasing screening if a patient is BRCA positive that I could find. And then here we just go into the mismatch repair genes, which we've talked about quite a bit. These genes are about 15% in sporadic cancers, and this pathway is kind of the pathway that they take. When you see MSI high, that means that when they're testing these tumors, they find greater than 40% of the cells are affected by this instability. I just kind of saw 2 definitions, and the other was that greater than 30% of the actual microsatellite loci was affected by this instability. If it's MSI low, they think that this might be a mutation within the MUT-S homolog versus just methylation alone. For the MMR, there's these mismatch repair gene mutations. They find that there's a predictive marker for chemo resistance, and so down the line, as we study it more, we may decide that, okay, because these patients tend to get chemo resistance, do we need to only do post-operative chemotherapy, or is there a benefit in adjuvant chemotherapy in these patients? Additionally, if you have a mismatch repair gene mutation, the effectiveness of 5-FU chemotherapy appears to be decreased, and so you need to think about using another chemotherapy other than 5-FU based. And then there's also potential for kind of immunotherapy using checkpoint inhibitors, and then if there's a BRAF mutation, then those are worse outcomes, which we've talked about. And then real quick, kind of at the end of my talk, I just wanted to go into the specific syndromes. I think these are things we're a little bit more familiar with. This is the Apc gene mutation, the familiar adenomatous polyposis. They have just thousands and thousands of polyps within their colon. These patients need an annual colonoscopy at age 10 to 15, and then a colectomy in their late teens to early 20s. 100% of these patients will get colon cancer by the age 40 if they do not have their colons taken out. Additionally, they will need an upper endoscopy starting at the age of 20 to 25. Here are some associated syndromes. Gardner's, which is the desmoid tumors, Troco, which is the CNS tumors that you can also see with FAP. Lynch syndrome, which I think a lot of us are familiar with. If you have the diagnosis of Lynch syndrome, which is a mutation in one of those mismatch repair enzymes, you have a 70 to 80% lifetime risk of colorectal cancer. It's also associated with increased risk for endometrial, ovarian, gastric, ureteral, and small bowel malignancies. These are the kind of 2 criteria that you can use to kind of just give you an idea if the patient would have Lynch syndrome, and then you would do genetic testing to confirm that diagnosis. For surveillance and treatments, you want to start colonoscopies at around the age of 20 to 25 every 1 to 2 years, and then endometrial cancer screening for women at the age of 25. And then the last thing is just new targets for screening. The genetics of colorectal cancer, as we know more and more about it, we can potentially improve our colorectal cancer screening. And so the one that I think a lot of people have heard of is this Cologuard, where they're testing the stool DNA for some of these mutations, such as KRAS and the methylation, and then a few of the other, the Epi procolon blood test is a kind of a new development as well. That's the end of the talk. Any questions?
Sorry, I had a brief question about how some of these mutations change.
Go ahead, whoever.
I'm sorry, Dr. Clifton. Go. I'm sorry.
Bobby, what's your question?
I was just wondering how the discovery of some of these mutations affects the eventual sort of systemic therapy that they get, like whether or not we're still giving MSI high, like stage 3 tumors, FOLFOX, and if you do find a BRAF mutation, whether or not they get FOLFOX plus, like dabrafenib, or if they're getting a different sort of systemic regimen.
Yeah, I'm not gonna be the best one to talk on that. I do now. I know, like in those tumor boards, I feel like they mention BRAF and KRAS, and a lot of times I'm like, I don't know why they're talking about all this stuff, but
yeah. So here's what I would know for the ABSAT. You got to know FAPA, Lynch syndrome. You got to know all those genetic syndromes. And then I think you should know that if they're RAS wild type, they can get an EGFR inhibitor. If they're RAS mutated, they cannot. So that's the most probably relevant therapeutic thing. And then Bobby, you mentioned MSI high. We know that MSI high tumors are less likely to metastasize, probably because the body's immune system responds to them. And it does change, like if you have a high risk stage 2, you will not give chemo for them because we just know that chemo doesn't work as well. Stage 3 is more controversial. Currently, you would still give chemo for a stage 3 MSI high tumor. Stage 4 is where it gets much more complicated, although stage 4 MSI high is actually pretty rare. But that's where checkpoint inhibitors would come into play, is in the stage 4 setting. But the hard thing is that, for right now, the guidelines would basically say you should treat with kind of traditional cytotoxic chemotherapy first, and then everything else would be second line, with the exception, I would say, of MSI high. Now, MSI high checkpoint inhibitors have been approved for all GI cancers that are MSI high. So it's controversial, like what you would do first line. I think, probably in an academic center, you'd probably get a checkpoint inhibitor. In the community, they might still be giving kind of traditional chemo. As far as the BRAF inhibitors, that's all second line. So for right now, like dabrafenib is considered after failure of more traditional chemotherapy.
Thank you.
So it's complicated, and for the ABSAT, I would just know about EGFR inhibitors and RAS. That's probably kind of the level that you guys should be aware of at this point.
So there is an ongoing alliance trial looking at adjuvant tenelizumab compared to FOLFOX in stage 3. So that could change. The other is PD-1 in therapy is approved for all MSI high tumors, not just GI tumors, but most of the time they are GI tumors.
And that's only for metastatic, right, Travis?
Yes, that's correct. Only for metastatic. So, I mean, right now, until we get that data, basically the medical oncologist for stage 3, you know, they'll, if it's like one lymph node or if it's stage 3A, they might not give it. The other thing they look at is, you know, what's the predicted toxicity to 5FU therapy. So it's very much a judgment call right now, and nobody really knows the right answer.
All right, thank you guys.
All right, good job, Kyle.
Yes, sir. I'm in the holler right now.